Hi everyone. So my name is Jiani Lee, and I am currently a senior at University of California, Los Angeles. Today I'm going to be talking about the independent research project that I did in the summer of 2021 at Caltech with Dr. John O'Doherty. And the project was about relating psychiatric symptoms to gain loss learning using recurrent neural networks. So before we get into the nitty gritties of recurrent neural networks, let's just take a step back and talk about why we need to do this kind of research. So my research was really motivated by this need for precision psychiatry. So it is established that there's great heterogeneity within categorical diagnostic groups. So for example, people who are diagnosed with depression can have very different neurobiological features, behavioral features, and this explains why they might respond to the same treatment differently, even if they have the same diagnosis. So in clinical setting, what we often see is that the patient and the clinician have to go through a long trial and error search for treatment before they finally find one. And sometimes this optimal treatment may never exist. So this is why in the field, many researchers are advocating for a dimensional classification system that may better map onto the patterns of neurobiological, behavioral, and clinical factors. But the problem is this classification system is likely going to be high dimensional because people can vary on a lot of dimensions. So this gives us a reason for applying machine learning, which our algorithms are good at dealing with high dimensional data in the realm of precision psychiatry. So currently in precision psychiatry, there are two lines of research. One line of research aims to match existing treatments to patients. So they would, for example, measure a patient on a variety of symptoms, and then from that, they construct a profile of symptoms for each patient. And then once we establish a relationship between certain type of symptom profile and the kind of treatment response, we can then go on and measure every patient on these multiple symptoms, construct a profile, and then from there we know what treatment to use for each type of patient. So for example, let's say a patient exhibit a constellation of symptoms, including high anhedonia, which means having very low motivation, and physical fatigue, but moderate sadness. And research has shown that if you match this type of patient to components of the cognitive behavioral therapy that specifically target low positive affect as opposed to, say, high negative affect, then treatment efficacy is actually higher. However, there are two questions about this line of research. One is that just by mapping symptom profile to treatment response doesn't tell us anything about the mechanisms that drive this constellation of symptoms. So we never know why these symptoms often coexist with each other. This would also mean that every time we want to diagnose someone and give them a treatment, we have to assess them on many, many symptoms, which is not always practical. So this is where the second line of research comes. So this line of research aims to optimize existing treatments and also develop new treatments. So this is like a schematic representation of what this line of research aims to do. So if we establish a relationship between symptom profile and the associated behavioral and neural profile, and we also know that certain symptom profile predict certain kind of treatment response, we can actually understand the symptoms better, right? Because now we find the behavioral and neurosignatures for this configuration of symptoms. And also, we have opportunities to develop novel treatments that actually target the mechanistic issues as opposed to the symptoms. And finally, if these tripartite relationship is established, we can actually just use some behavioral tasks that measure this behavioral profile to use it as a diagnostic tool. So instead of assessing everyone on all possible dimensions of symptoms, we can just use a simple behavioral task that measure this behavior that we know is associated with a symptom profile. And that way, this can be a proxy to accurate diagnosis. So let's finally talk about recurrent neural networks. So this is the architecture of an RNN. So it has the same architecture as other neural networks. So it has an input, some hidden layers, and an output. But what's special about RNN is that information actually flows out of the network and then goes back to the network again. So in this sense, information recurs within the hidden layers before being outputted. So value of each cell is updated based on the inputs plus last values of the other cells. So if we unroll this RNN, it's essentially multiple copies of the same RNN connected together. But the problem with this original RNN architecture is that what if the output at time t actually depends on the input at time 0? So if information just recurs in this chain of neural networks without any kind of mechanism that determines which information to keep and which information to throw out, eventually you'll lose information that comes in at a very long time ago. So then researchers just introduced this special type of recurrent neural networks called long short-term memory networks. So the basic recurrent property is still there, but within each cell, there are these gates that determine which pieces of information to keep and which pieces of information to throw out. And now we also have two types of output. One is this short-term memory, which essentially is the output of every step of the computation. And we also have long-term memory, which can be thought of as a conveyor belt that carries information from the start to finish. And because we have all these gates, we can decide which information at each time point to add to the conveyor belt and which information to throw out from the conveyor belt. So in this way, we solve the problem of long-term dependencies. Okay, so RNN is great, but why do we need RNN in precision psychiatry? And especially in this project. So, so oftentimes, if we want to fit a model to some behavioral data, it is unclear when model fitting should stop, right? So if you fit a model to a data, you get a pseudo or a square, and you get some unexplained variance. You don't know whether it's because the model is inadequate or there's just natural randomness in behavior that just cannot be explained. Also, even if you know that like it's because of inadequate model, often you need manual engineering to improve model performance. So here comes the advantages of RNN. So it is completely data-driven, which means that it doesn't require any, it requires very little assumption on our end. And it also has like many parameters built in. So it's good at capturing patterns in high dimensional space, which we know is what we need in research within precision psychiatry. And also RNNs can learn time dependency. And in this case, since we want to model decision-making behavior, which incorporates lots of temporal information integration, perhaps the recurrent property of RNNs would allow us to model this temporal information integration properly. So the whole project was based on this research done by Desfuli et al. In 2019. So in this study, they had healthy, depressed, and bipolar subjects. And they had them do a 2-arm bandit task. So in this task, they were asked to pick either left or right. And then if they picked the right one, the correct one, I mean, they were shown an image of, say, an M&M. And if they picked the wrong one, they got nothing. So there are 12 blocks, and reward probabilities differ across blocks, but are consistent within each block. So for the analysis, they fitted a group level RNN, so they fit an RNN to the entire healthy population. And then also they fit different kinds of reinforcement learning models. And then compare these two models with logistical regression to predict the accuracy in their choices and also the similarity in strategy use. And then they used off-policy simulations to interrogate the RNN to figure out what exactly did the RNNs learn of participants' behavior. And finally, they used RNNs to predict the diagnostic labels. So results show that essentially RNN outperformed all other models in prediction accuracy, so predicting which actions they made. And from off-policy simulations, the researchers concluded that the participants in the depression and bipolar groups adopted some very bizarre strategies, like just hitting left 3 times and then switching to right 3 times and then oscillating between left and right. And this pattern of bizarre behavior was detected only by the RNN because no one would have thought of building this type of behavior in a reinforcement learning model. And finally, RNN predicted diagnostic labels well. So the prospect of applying RNN to model decision-making behavior inspired a current project of like applying RNN to model gain-loss behavior. So in our gain-loss task, we had 192 trials organized into 4 blocks. So a gain block is followed by a loss block, and then another gain and another loss. So in a gain block, if winning means that you get 25 points, losing means that you get no points. But in a loss block, winning means that you get no points, losing means that you get 25 points subtracted from your current points. So in each trial, participants were presented with 3 stimuli with win probabilities from 0.2, 0.5, and 0.8. But only 2 of them were presented. So this is a schematic representation of each trial. So it starts with a fixation, and then from the 3 available stimuli, 2 of them were randomly drawn and then shown to the participant. And then once participant made a choice, they saw the outcome, which varied depending on which block you're in. And then halfway through each block, reward probabilities are shuffled. This means that participants have to relearn reward contingencies. This allows us to tell learning versus relearning rates. So what's different from Desfuli et al. Is that, first of all, we had a much more complicated experiment. So we had more stimuli, so more reward contingency to remember and update. So in Desfuli et al., they only had two stimuli, whereas in our case, we had 3 available per block. And then we have 4 blocks, so 12 stimuli in total. And we also built in reversals of reward probabilities, which means that participants also had to update their reward contingencies. And finally, we had gain learning versus loss learning. So all of these features made the experiment more complicated, both to the participants and to us in terms of modeling. And also we had a much larger sample size. So we had around 1,000 participants, whereas in this Foley's case, they only had around 100. So this is a map of my project. So in the first step, we aim to really understand what the RNN is doing. So in particular, we asked what can or cannot be captured by an RNN. And to answer this question, we used simulated data with known parameters and see if the RNN can fit the simulated data well. And in the second stage, we started to apply the RNNs to real human data. And then we wanted to compare how RNNs perform to how reinforcement learnings perform. So at this stage, we asked, are the recurrent neural networks better at predicting human actions than the reinforcement learning model? And also, if there are gaps between the performances of RNN and RL, can we use it as a function? Can this be a function of psychiatric symptoms? And in the final stage, we want to ask what were the subjects really doing and what did the RNNs really learn? So currently we're at the second stage. So we are still at the model comparison stage. Okay, so the first step of the project was to just understand what the capacity of the RNN in capturing decision-making behavior. So as I said, to do this, we use it to model simulate data with known parameters. So in particular, we wondered, is the RNN sensitive to differences in learning rates? And this is not only the difference between individuals, but also the difference between gain block versus loss block, right? Because you can imagine a person can quickly learn rewards, but not so much in losses. So can the RNN tell apart these two? Also, is the RNN sensitive to handedness, which means that if someone just sticks to one side of the action, can the RNN model this type of behavior well? And also, is the RNN sensitive to someone that arbitrates between response stickiness versus stimulus stickiness, and perhaps other degenerative strategies? So the architecture of the RNN that we used in the current project is shown here. So here we have the same good old RNN cell. What's different is that so the input, so we had to decide what input we want the RNN to learn. So eventually we decided that, okay, the RNN first needs to learn what was the action in the last trial. And here by action, we mean that what was the previously chosen stimulus. And it also has to learn what was the last reward. And the reward, we recoded it into integers, so 1 to 4, which represents a reward in a gain trial, and reward in a loss trial, a reward in a loss in a gain trial, and a loss in a loss trial. And for the remainder of the input vector, we decided, okay, the RNN also needs to learn what stimuli were presented in the last trial, and also what stimuli are currently available, but not necessarily presented. So to encode the stimuli, we try different kinds of encoding, but ultimately settle on this one hot encoding. So overall, this gives us a 50-element vector as input into each trial. So to simulate data, we used in our reinforcement learning model that's specified here. So in this model, stimulus utility is calculated by this Q value from last trial, plus Wednesday-Luz shift bias, plus bias for stimulus stickiness, plus bias for action stickiness, and hand bias. And here are the free parameters that we got to play with. So essentially, at this stage, what we did was manipulating these free parameters and looking at how well did the RNN model different kinds of reinforcement learning agents. And for the sake of time, I'm just going to skip all the steps that we did here. So in conclusion, after trying out all kinds of strategies and manipulating all kinds of parameters in the RL model, we concluded that our RNN can approximate reinforcement learning behavior well, at least, even without knowing that the objective of the task was reward maximization, because RNN is inherently model agnostic. Furthermore, we know that the RNN is sensitive to differences in learning rates, handedness, response stickiness versus stimulus stickiness. And finally, another results that surfaced from this stimulation is that if you vary, if you alternate between strategies within a single person, but across people, there is no variation, RNN can actually approximate this type of behavior well than, say, if you have lots of between subject variations, but within each subject, they adopted consistent strategies. Okay, so once we know that RNN seems to model at least reinforcement learning behavior well, we wanted to apply it to real human data. So at this stage, we wanted to compare the model performance of RNN versus reinforcement learning models on real human data. So because this the project was about relating decision-making strategies to psychiatric symptoms, we decided to start from depressive symptoms, which was measured by back depression inventory, so BDI. So we took participants' BDI scores and then split them into quartiles. So this is a graph of all participants, the distribution of BDI scores. So you can see that the distribution is almost exponential, with many subjects having very low BDI scores and very few having high BDI scores. So you would think that if you split them into quartiles, those in the lower quartile would have more similar BDI scores and probably exhibit more similar learning strategies, whereas those in the higher quartile are more spread apart in terms of BDI scores and thus may exhibit very different learning behaviors. But as we'll see in a minute, it's actually not the case. So to compare reinforcement learning model and RNN fits, we use the 5-out cross validations. So for RNN, we train each RNN on n-5 subjects, and here n means the number of subjects in each quartile group defined by BDI scores. So we took out 5 subjects from each group, trained an RNN on the rest of them, and then tested this RNN on the 5 holdout subjects. So for the RL, we did something similar. So we took out 5 subjects, fit RL to each of the n-5 subjects, And then we average all the parameters together to get a group average parameters, and then fit these parameters to the 5 holdout subjects. And the index for model fit quality was log likelihoods. And we also did different types of cross-validation. So the one I just described above, where you where you take out 5 subjects from this group and then train model on the rest, is what we call in-group cross-validation, because you're training and testing on the same on subjects within the same group. We also did cross-group cross-validations, which means that you train a model on everyone in Q1 and tested it on 5 holdouts in Q4 and vice versa. And finally, random group cross-validation means that you train a model on a random sample from all 4 groups, and then test this model on 5 holdouts in either Q1 or Q4. So essentially, in all 3 types of cross-validations, we had the same number of holdouts, and also the holdout participants were the same across different types of cross-validations. And we also have similar training sample sizes. So by using the 3 types of cross-validations, we wanted to ask 3 questions. So the first one is, does RNN fit the data better than reinforcement learning model? And the second question we wanted to ask is, do individual differences in depressive symptoms reflect individual differences in gain-loss learning? So in other words, how behaviorally based are BDI scores? And to do this, we would compare, first of all, the in-group cross-validation results for RNN versus the cross-group cross-validation results. And we also would compare in-group versus random group cross-validation results. And the final question we asked was, do individual differences in depressive symptoms reflect individual differences in the tendency to do reinforcement learning? So to answer that question, we compared in-group cross-validation results for RL model and the cross-group cross-validation results. So first, after comparing RNN versus RL, we concluded that just across the board, the RNN predicts in-group actions better than the RL. So this means that you test and train, you train and test both RNNs and RLs within the same group. And for all groups of subjects, regardless of what subjects you hold out, RNNs just do better than RL, which makes sense because RNN with so many parameters should be able to model behavior better than RL. Okay, so we confirmed that the first question is indeed a case that RNN fit the data better than RL. Okay, so the second question is, how behaviorally based are BDI scores? In other words, how valid is it for us to split people into different BDI groups? And is that reflected in their behavioral patterns? So to do this, we compared in-group versus cross-group RNNs. So on the left-hand side, we can see that for Q1, the cross-group RNNs actually perform better than the in-group RNNs. Whereas for Q4, which are consisted of subjects who are severely depressed, it's the in-group RNNs perform better than the cross-group RNNs. This suggests that for Q1, members don't seem to share decision-making strategies a lot, because if you train RNN on Q1 and then test it on Q4, it actually does better than if you train and test on the same group of people. And furthermore, we compared in-group versus random group RNNs. So for Q1, in-group RNNs did similarly with as random group RNNs. And the same results were the same result was true for Q4, but the tendency was that the in-group RNNs did a little better than the random group RNNs. So this would again suggest that for Q1, members don't seem to share decision-making strategies. Whereas for Q4, because we only had 30 iterations, we probably need more data to confirm this relationship. But for now, at least the results seem to be that there is this tendency that in-group RNNs do better than random group RNNs, which would suggest that members within Q4 might be more behaviorally similar with each other than members within Q1. So as an exploratory analysis, I also correlated the prediction accuracies of RNNs done on different training sets. So this analysis would allow us to tell if subjects that are better described by one training set also better described by another. Because if so, grouping based on BDI scores might not be very behaviorally based, at least. So for Q1, the results show that the in-group RNNs actually correlated with random group RNNs the most. So this would mean that subjects who are very well captured by in-group RNNs were also very well captured by random group RNNs, which were not trained necessarily on the in-group members. Whereas for Q4, cross-group RNNs correlated with random groups RNN the most. This makes sense because this would mean that subjects who were captured well or not well by people in Q1 were also captured well or not well by people in some random grouping. So this, again, might suggest that Q4 is a more behaviorally distinct group that shows more consistent learning strategies, whereas Q1, people in Q1 might exhibit more variable learning behavior. Also, I correlated in-group RNNs with in-group RLs. So this would allow us to tell the extent to which subjects' RL abilities are captured by in-group RNN. So for Q1, these two were not correlated very well. For Q4, they are correlated, but the correlation was rather weak. So overall, this showed that there were substantial individual differences in RL behaviors, but the individual differences were larger in Q1 and smaller in Q4, which again suggests that Q4 might be a more behaviorally homogeneous group. And this homogeneity might be explained by simple reinforcement learning. So to summarize, in the first part, we compare the model fits of RNNs and RL. And from there, we conclude that Q4 may be more different from Q1 than from the entire sample, whereas Q1 may be as different from Q4 as it is from the rest of the group. And also by comparing in-group versus cross-group RNNs, we can also see that for Q1, the cross-group actually does better than in-group, which suggests that people in Q4 might actually fit people in Q1 better than other people in Q1. Whereas for Q4, it is the opposite. So other people who had similarly severe depression fit their behavior better than someone from Q1. In terms of correlations, So here for Q1, in-group RNN correlated with random group RNN really well, which shouldn't be the case. So this would suggest that, again, Q4 may be a more unique group, more coherent group than Q1. So the conclusion was that in many ways, Q4 might be a more behaviorally distinct group than Q1. And also high BDI is associated with a more unique gain loss learning patterns, but not in low BDI. This would suggest that if we were to use this gain loss task in clinical setting, it could be effective in parsing out the severely depressed people, but less so for the rest. And also, since most people in Q1 had BDI scores of zeros, so remember the distribution of BDI scores, a lot of people in the low BDI group had 0. But some of them were actually better predicted by people from Q4 than from Q1. This would suggest that a lack of depression diagnosis does not exclude the possibility of having certain instrumental learning deficits. So what are some future directions for us? So first of all, we know that RNN across the board does better than RL in predicting decision-making behavior. So a future step could be to use the gaps between RNN and RL as and use that to maybe predict psychiatric symptoms. From there, we can probably cluster individuals into different subtypes, because essentially this gap between RNN and RL would tell us to what extent can this person's behavior be explained by reinforcement learning, which can be clinically meaningful. And another future step would be this off-policy simulation step, which essentially involves feeding artificial input data to the RNNs that we train, and then looking at the output that that the RNN gives. So this would allow us to see what did the RNN really learn from the behavior, and also maybe relating the strategies learned by the RNN to the psychiatric symptoms. So that's all for my presentation. Thank you so much for listening. And I definitely look forward to keep pursuing this project.